Hey, it's Nurse Key here, and welcome to the New Nurse Bootcamp. So today I want to talk to you about the New Nurse Roadmap. Did you know that a new nurse is considered anyone practicing within their specialty within less than 1 to 2 years? So I feel like that takes a little pressure off. You have about 1 to 2 years to actually master your specialty, or at least to get the fundamentals. And I kind of want to show you what the roadmap of that may look like from starting the job to that 1 to 2 year mark of where you should be. So starting with like day one, we know that we passed the NCLEX, we finally got our job, we're getting ready to start. So nurse residency, or your nurse orientation period. All hospitals and facilities do not do this all the same, of course, but every nurse should have some type of orientation period. Whether you're in a skilled nursing facility or a SNF, that may be 2 to 4 weeks. In the hospital or acute care, Med-Surg tele, it may be 6 to 9 weeks, and then critical care, ICU, maybe 8 to 12 weeks. So within that period, you're going to be assigned a preceptor. In nursing, the joke is they may be voluntold, but you will have a preceptor, which is like a little bit more advanced nurse that will be able to guide you in some of the unit policies, your clinical skills, and help with critical thinking and prioritization. So you'll generally have like one or two, a few shifts to shadow your preceptor. So I don't want you just to shadow them to see, okay, we have these patients. You kind of need to watch to see how they actually set up their day, how they receive handoff, how they go through the chart, how they structure their time, and how they manage each patient load. A lot of times nurses think in their heads of don't be afraid to ask questions at the appropriate time, which would be while you're sitting at the computer, you have downtime. Ask him, hey, okay, so why did we go into this patient's room first? Or what about this medicine? Or when a new order comes in, how do you prioritize that based off of what else we have going on with other patients? So questions like that help you gain some insight of how a skilled nurse thinks. So your preceptor also is there to close knowledge gaps. So we only learn so much in nursing school, and generally that's in a controlled environment, and then you get into the real world and it's nothing controlled. So now your nurse is able to see in real time how you can manage your skills, what these disease processes look in real humans, and how you can manage those while collaborating with your team. So you have your preceptor, and then you're gonna shadow, and then you're gonna have your own patient load. So depending on what specialty that you choose, if it's skilled nursing facilities, you can have anywhere up to 30 patients at a time, depending on what state and shift that you work. Generally, acute care, Med-Surg tele. Med-Surg is 1 to 6 to 7 to maybe 8, depending on the state, and then tele is 1 to 4 to 5 nurse to patient ratio, and then critical care is max of 1 to 3. So you're generally going to start with one or the minimum amount of patients for that specialty, and then you'll increase by acuity and as your skills progress as well. So take advantage of the lighter load, take advantage of them giving you breaks and being able to like breathe during your shifts, because that always won't be the case. So when you have a lighter load, take the time to actually build your foundation. What does that look like? When you have handoff, actually have a report sheet. Know what the report sheet and your factors of receiving handoff will be, like demographics, the admitting diagnosis, your history, the body systems that now we're going to start to receive in handoff. Be prepared. That way when somebody is giving you handoff, you don't have to keep looking over the paper and stuttering over it. And then also remember that you can fill in the gaps and actually validate everything in handoff with the patient chart. So you'll start to create your own flow. So you get your assignment, you get handoff, you start to look at the report, then you do your assessment, your baseline assessment of your patient, and so start to prioritize like how your day will flow. Then from there, you'll look over your brain or your charting system, and it'll kind of show you what is the plan of the day, what is the care plan for the day. And so I like to do mine in time chunks, which is like every 2 hours. If I work day shift, I write on my paper 8, 10, 12, 2, 4, 6. And I write, okay, do we have meds? Do we have PT? Do we have to get them out of the bed for meals? Do we have to walk or ambulate or do a road test? I try to write that down. And so it's like in my mind, I already know, okay, at 2 p.m., I already have something. So even if something happens in my day where it can kind of disrupts our flow, I still have something in mind like, oh, okay, we're back on track. So I'm not having to check the computer every 2 seconds, because that's not often realistic. Yes. Now, second part is after orientation. Now, of course, the preceptor will be talking with the educator and the management team to say, okay, this person is progressing as expected, or they may need a little bit of time. And then they can also say, okay, these are some gaps of where we see you might be lacking at. Now, once they approve you to actually be off of orientation, and you feel comfortable technically too, they're going to release you onto being an independent nurse, having your own patient assignment. They're taking the training wheels off, but that doesn't mean that you're not going to have support from the nurses, because generally nurses all care for the unit and the patients on the unit. They're not going to let you generally drown by yourself, but also know to ask for help. But that's why it's important to kind of gather your own routine during orientation while you have an assistant with the preceptor, to when you're by yourself, you can kind of lean on that and then kind of supplement with some questions from the other nurses. Or if you need help with turns, or if you need a question about the medication, they're there to provide support. So the biggest thing when you're actually by yourself as a nurse, when they're actually under your own patient care, under your license by yourself, remember the devil's in the details. So go back to your foundation. Know who is on your doctor's team. If you have a question about medicine, you can sometimes call the pharmacy. You can say, hey, is this compatible? Can I Y-site this? Or ask the doctor, okay, this patient seems to be trending this way. It may not be fully important just yet, but I'm letting you know so we could get ahead of it and try to see what you think about it. Know what pending doom looks like, whether it's in vitals or the person is starting to trend in a negative way, and sometimes the patient will tell you, hey, I don't feel good, like I feel like something is coming. Learn to listen to the patient, and then go back to the basics. It doesn't matter what kind of patient I have or what unit. If I'm not familiar with the medicine or a diagnosis or a treatment plan, I will look it up. Don't be afraid to look it up. Don't assume, and don't try to act like you know everything. You don't know. You're continuously learning, so that's okay. Look it up. Go back to your basics. Even in nursing school, make a care plan. If you have not had a patient with burns or a trauma injury, make a care plan for it. Okay, what is my main concern with this patient? What am I scared of that may happen? What is the worst thing that could happen with them? How are we going to treat it? What is my nursing considerations that I need to keep in mind? What drugs and what adverse effects are we concerned about with this patient? And how do I know that they're getting better? So all the things that nursing school gave you was just a toolbox to get started. You have your knowledge of your diagnosis and your disorders, your medications, and then you understand like how to communicate with your patient. But now you have to integrate that with real life situations, and you have to apply critical thinking to each scenario. So I hope this helps. This is lesson 1 of New Nurse Bootcamp. We went over the New Nurse Roadmap. Stay tuned for lesson 2. Hey, Nurse Key here, and welcome to episode 2 of the New Nurse Bootcamp. So today we're going to talk about giving report. Now this one's for my long-term care girlies, okay? Girlies and guys. Of how to give handoff or how to receive handoff, and what's the key factors to know for each resident. So of course you're going to go with demographics. What's their name, age, their gender, sometimes their preferred name to be called, their code status for sure, allergies, and the doctor on call. Then you're going to worry about their admitting diagnosis, their medical history, was their mobility status, do they use a cane, walker, wheelchair, are they incontinent about in bladder, do they have any pending appointments that I need to know about, are they going to dialysis, any wound care treatments ordered. What about their tubes? Do they have oxygen? Do they have a CPAP or a BiPAP that needs to be placed on at night? Do they have a nebulizer treatment? Do they have a PEG tube, G tube, or a Foley catheter? Do they have any central lines that need IV infusions? Well, simple like that. Now, for the hospital, let's say you're working on Med-Surg. It's going to be the same thing, but a little bit more structured. So with Med-Surg, again, your ratio is going to be, well, let me say your skilled nursing facilities can have anywhere from about 20 to 30 patients per nurse, whereas a Med-Surg unit may have a max of 8 depending on the state. So again, you're going to have demographics. You're going to ask about their admitting diagnosis and what was their chief complaint. So you can, when you actually talk to the patient, you can say, well, has that been resolved? Is it the same? Or where are we at with that? The history. Then you're going to go through your body systems. You're going to ask about neuro, cardiac, respiratory, GI, GU, skin, mobility, their plan of care for today, any access lines. All right, and then for critical care, it's going to be, again, almost the same format, but hey, Nurse Key here, and welcome to the new Nurse Boot Camp. 3 tips for handoff at the bedside. Not only is it the best policy given by your facilities, but it covers you, the other nurse, and your patient. So 3 things to remember: breathing, bleeding, and bowels. Make sure your patient is Make sure your patient is breathing, and what is their baseline? It should be unlabored, no signs of distress, no shortness of breath, and symmetrical rise and fall of the chest. Bleeding, we of course don't want them to bleed, but actually have no extra discharge. We want all tubes to be in place, all IV access to be intact, clean, and dry, and all wounds to be secured. And bowels, we want to make sure we know if they're incontinent or continent, and that they're not soiled. So these are 3 major highlights to know while you're giving handoff. You can check this at the bedside. Don't be afraid to pull those covers back, like they say in nursing school, and get to it. All right, that's our quick tip for the new nurse boot camp: breathing, bleeding, and bowels. See you for the next episode. Okay, Nurse Key here, and welcome back to the new nurse boot camp. So this is episode 3. After you got report, what's next? So we talked about giving report at the bedside, right? And this is generally between nurse and nurse. Now let's include the patient. So I like to do what is like a mini assessment, just so I have a baseline before I get like the full information from the patient chart and then do my full head to toe. So my mini assessment would be going up to the patient, introducing myself. I can get a gauge of their mentation. Are they able to wake up by just voice, or are they already awake or alert? Do they only awake to touch, or are they only stimulated with pain, whether it's a sternal rub or, a pinch? How much level of interaction does it take for your patient to be engaged and maintain a level of alertness to actually function? So then also you get to ask your questions of like, okay, can you tell me your name? Do you know where you are? What's your date of birth? What year are we in? Just to see what their gauge is of their memory as well. That also, this level of interaction tells you, can they hear, can they see, do they appropriately turn their head to which side that you may be standing by, are they able to properly answer the questions, or are they properly able to follow the commands that you're asking them to do. You're, again, we talked about the breathing, bleeding, and the bowels. We're going to check their skin for any urgent things that we may need to attend to. And then the respirations, right? The breathing. Do they look like they're having shortness of breath or signs of distress? Is it labored breathing? Is it unsymmetrical breathing? Any bleeding? And then bowels, are they soiled? All right, so if my patient is not in urgent need of care at this moment, I'm going to take my handoff report. I'm going to go to the patient chart, and now I'm going to not only verify what I was given in report, but I'm now going to fill out the full patient information and kind of gather what I'm going to be doing with this patient today. Whether that's medications, any new orders, whether it's labs, diagnostic tests that may need to be happening, their treatments, physical therapy, occupational therapy, or just everything in between. Wound care. I'm going to try to get as much information so we can plan accordingly, and also so I can let the patient in on what our plan of care is for the day and write it on the whiteboard, so everybody's on one accord. Um, so you have to make sure that you understand that handoff is kind of like a skim of the person. They're going to give you the most vital things that are needed to kind of like change hands of that patient, but it is your due diligence to verify and validate the information given and know your patient in totality, because the patients will ask you, the physicians will ask you, the family will ask you, and so you're kind of like the best representative of that patient for the day. All right, so that's it for episode 3, and we talked about what happens after getting your handoff report, how do you prepare for your day. See you for episode 4. Okay, Nurse Key here with the new nurse bootcamp. So let's talk about actually when you look in the computer system. So it doesn't matter what charting system that you're using, there are certain points that you have to find for each patient, just so you have like a full picture of what the plan of care is for that specific patient. So of course you're gonna need to know demographics. We consider this their name, age, gender, date of birth, code status, which means full code. They want everything: CPR, defibrillation, or DNR, which there's more aspects to that, of no intubation, no CPR, no compressions. Yeah, so it's either the main ones, 2 biggest ones are DNR or full code. It's necessary for you to know which one your patient is. What doctor teams are they on, or any consulted doctor that may be prevalent. What is their admitting diagnosis? So every patient comes to the hospital or a facility with a certain diagnosis, whether it is chest pain or a fracture. You need to know why they came and what was their chief complaint, the symptoms that they were having surrounding their diagnosis. Then their medical history. You need to know what is the plan of care. You can find this generally in the notes, the physician notes per day. They'll say these are the diagnoses that we are most concerned of during their stay. This is their medical history. These are the actual interventions that we are considering for this admission or this facility stay. And here's our plan. You need to know the pending discharge if they're in an acute care setting, the pending discharge date that you're looking forward to, and the medications that they're on. That way you can kind of also reassess, like, okay, what are the adverse effects of these medications, any contraindications that I should know about, any symptoms that I should look for after I give the medications or before, or nursing interactions that I need to perform before and after I give this medication. Just like blood pressure medicine, you'll want to take their blood pressure before you give blood pressure medicine, and maybe 15-30 minutes after. Pain medicine, you'll assess their pain, location, duration, and type of pain before you give it, and then you'll reassess within 15-30 minutes. So it's great to have like a full picture, and everything is found in the chart. And so while you're in orientation, it's great to play around with the computer. Just start pressing stuff. You don't have to document anything. Just start playing around with the different buttons so you can kind of understand where everything is located and what is the most useful to you in your role as a new nurse. All right, so this is just a quick tip on how to use your computer to get the full picture for your patient. Hey, it's Nurse Key, and welcome back to New Nurse Bootcamp. So today I want to talk about how to introduce yourself to your patient and start to build rapport. So of course you walk in and to get their attention, hey, my name is Kiara, I'm going to be a nurse today. Can you tell me your name? They tell you your name, and what's your date of birth? And can you tell me where you are right now? Do you know what year it is? All right, so now you can already have kind of your A&O times 4, or you gauge what their mentation status is and their orientation. All right, so, well, what brought you into the hospital or into the facility today? And they say, well, I was having chest pain, They go into the whole story. You say, well, okay, how are you feeling now? Do you have any pain? Are you having the same symptoms? Have they resolved? Have they maintained, or have they gotten better? All right, so now you kind of gauge where they are at, with that. And you could say, okay, well, I had a chance to look over your chart, after you've actually looked and kind of gather what the plan of care is, and we're going to do this, and this today, whether it's going to give your medicines, I'm going to get you out of bed for your meals, we're going to go walk in the hall for your road test, you're going to have physical therapy come by, speech therapy, occupational therapy, or a diagnostic test. But this way, once you had a chance to go over the plan of care, now you inform your patient, and now y'all can work together so everybody can be on one accord, and they also can be included and compliant with the plan of care for the day. And so patients love to be included. Sometimes we forget that this is somebody's real life that we are kind of like intervening in. So the best that we can do is include them and ask for suggestions of what they would most likely want from us. Or what their preference may be. So, okay, that was just a quick tip of how to introduce yourself to your patient and how to build rapport with them from the start. Hey, Nurse Key here, and welcome back to the New Nurse Bootcamp. So now we're going to talk about your baseline head-to-toe assessment. So I think that this is the most important when you get an admission, of course. When you come onto the shift, I always say if you do one good, thorough assessment when you first meet your patient, everything else is just kind of like a supplement. Okay, let's see what changed. I personally do is like a photogenic memory. I'm like, oh, I know where the IV is. I know what it was looking like. And so I know if anything changes. I'm very kind of like observant when it comes to my patients. So a baseline assessment, let's start at the top. Neuro-wise, of course, when you speak to your patient, do they seek back? Are they alert? Are they a little lethargic? Does it take a lot for them to interact? Are they able to answer with just speech? Do you have to touch them to get their attention? Do you have to inflict pain to get them a stimulation? And then you'll ask your questions. Are they, yes, again, alert, lethargic? Are they in a stupor? Are they obtunded? And then are they able to tell you your name? Are they able to tell you the date of birth, where they are, what year they are in? So that kind of determines their memory. Now you're going to look at, sometimes they'll forget to tell you certain stuff. So with certain patients, you'll have to actually ask them directly. Do you have any vision problems? This will be obvious if they wear glasses, but what if they wear contacts, or what if they're at home? Ask them, do they have any hearing problems? Do they have hearing aids? Sometimes they're not responding because they can't hear. It's a question to ask. All right, so vision, hearing, any dentures, partials in their teeth. Are they able to chew? Do they have any broken teeth, especially after intubation? Any, like weak, loose teeth in their mouth. You'll look at their swallow. Are they able to swallow without coughing, choking, gagging? If not, that would be an aspiration risk. You're going to look at, hey, can you raise your eyebrows? Are they symmetrical? Can you smile? Is it symmetrical on both sides? If they grab your hands, and can they release? How is their grasp? Is it like equal force? Are they able to flex their feet and push back on your feet with equal force as well? Things like that. Cardiac, you'll look if they're on the monitor, how's their EKG or their rhythm, how are their vitals, their blood pressure, their heart rate, is their pulses palpable, is it +2, +3, are they bounding, are they weak, what about their skin, do they have edema, is the circulation okay, is it cool, warm to touch, pale, what else, respirations, you'll see if is it even, symmetrical, chest rising and falling, do they need supplemental oxygen, whether that's a nasal cannula, are they on a high flow, are they vented, do they use a BiPAP or a CPAP, what is their oxygen saturation saying on room air or on their current oxygen, is that matching with what the orders have allowed. Generally COPD patients may be allowed to have 88 or greater with their oxygen source, and so that could be their normal. But you could always check your orders to make sure you know what that patient's baseline is supposed to be. GI, you look at what is their bowel sounds, when was their last bowel movement, do they have bowel sounds, is their stomach distended, is it soft, is it rock hard, is there any discoloration, remember on the stomach or even on the flanks. When they have a bowel movement, is it normal, does it have blood, is it of normal consistency, is it hard, is it runny, if they have loose bowels, how long or how many episodes have they had loose bowels, is that considered diarrhea, do we need to get a C. diff sample, anything after 3 loose stools generally will get a C. diff sample, a stool sample, and it goes to the lab. You'll look at nutrition for their GI system as well. Are they able to eat? Are they NPO? Any chewing or swallowing difficulties? Do they have an NG tube? Do they have a G tube? Do they have a PEG tube or a TPN? For GU or the urinary system, do they have urinary retention? Do they need to be bladder scanned? Are they incontinent or are they continent? Do they have a Foley? When they do urinate, is it of normal consistency, color, and smell? What is the volume? Do they have adequate urine production, or are they oliguric, which is moderate, to anuric, which is no urine production? And understand what is their baseline. Even if they're dialysis patients, you can't always assume that they do not make urine production. It's best to ask. And also, you can look back on the charting for the other shifts if they've been there that long to see what their consistent trend has been. Then you're going to look at like their skin, head to toe, any wounds, tattoos, or marks that may be present, any open wounds. Generally, if you're in acute care, you'll take a picture to document or write it in the chart and have a wound care consultation. Or if there's already one and wound care has already been consulted, you'll just continue to do the treatments and to monitor progress. Skin, also you would want to see if they're incontinent too, and their total care, you know, to turn them off of their full side every 2 hours so you don't continue to wear down their skin and make the wounds worse or to create a wound. You look at your access site, vascular access, whether it's a peripheral or a central line. You look at the site for any redness, heat, where is the line patent, is the dressing actually intact and sealed around the perimeter of the dressing. If not, it has to change if the dress. If the dressing is not intact and sealed, then generally it has to be changed because it's an infection risk. So whether that's a central line, an A line, a PIV, look at your site. Make sure most facilities require the bio patch around at the hub of the the catheter to prevent infection. So you'll want to monitor that around your shift, and also make sure it's even not soiled even with blood. It could be dried, but then there's like new soil, like if it becomes damp, that would be something to change as well. And then you'll think about your tubes, whether it's JP drains, any other type of drains. Know what you're started at, and per shift generally you like to come in at 0. They should empty it from the prior shift. Any bags, Foleys, things like that should be empty, so you can know you started at this a clean slate, and then you'll monitor the drainage per shift. Generally, you'll chart that per hour and then see how that trends as well. Peg tube, G tubes, NG tubes, or even like ET tubes. Any tube that is actually inserted and can be marked at a certain distance, I like to check at the beginning of my shift to make sure I know what the baseline was, and if it moves, then I know how to reassess and will intervene at that time. Foley catheters, you want to make sure you actually, most facilities ask for you to do a CHE bath to prevent that line getting infected in a urinary infection as well. So you do a CH bath, and then you actually look to make sure it's not red or it looks like it's becoming infected. You look at the urine within the bag, and yeah. And then the rectal tube. If they have a rectal tube, you want to see what the output was of the rectal tube and make sure the balloon is still inflated. Per shift, you have to deflate and reinflate per facility policy. And lastly but not least, you look at your infusions, if there are any. If there's any continuous strips, or even let's say an antibiotic that was not finished by the time you took over, you'll see, okay, well, this one's still running and it'll end at this time. I like to usually set a timer so I can go in there and it's not beeping forever while I'm down the hall. And then if it's a continuous strip, you'll make sure that your bag is not close to being empty, so you'll have another bag on hand, and you'll get another chance to re-verify that it's running at the right rate in the right IV site or access site. So again, we talked about our baseline head-to-toe assessment, whether it is a new admission or you're just coming onto your shift. A head-to-toe assessment, of course, is like the baseline of you taking over for this patient, and it's crucial to how you do the rest of your shift. All right, see you for the next episode. Hey, Nurse Key here, and welcome back to a new Nurse Bootcamp. Can we take a moment to talk about time management and prioritization as a new nurse? And what does that look like? So generally we work 8 to 12 hours, but I'm going to use 12-hour shifts for this example. So every report sheet I have, I always leave a little space at the bottom to make my time blocks area at the bottom, but I just wrote this big so y'all could see it. So okay, so don't excuse my little dried out dry erase marker. I actually use it all the time at work. So every I put my 12-hour shifts into 2-hour increments. So from 8 to 10, 10 to 12, 12 to 2, 2 to 4, and 4 to 6. I fill out, I go to my patient chart, I see whatever my plan of care is on the same report sheet for that patient. Okay, so what I know, if I'm working day shift, and this actually applies for night shift too, it's the same increments, just flipped AM or PM, it doesn't matter. So I know, let's say for day shift, I know when I come in, generally at 7 a.m., blood sugars are already done, so I'm going to look up the blood sugar. By 8, you're going to give your insulin, and breakfast should be coming. When trays are on the floor, give your insulin, depending on your facility policy, and then you'll start your med pass as well. You'll give medicines, you'll get your vitals at that same time. Most facilities and most units have the same routine. It's crucial that you know your unit routine. Regardless of your patients, you have to have a certain foundation that keeps you kind of stable throughout your career. And so this is one of the ways that I keep myself sane. So the time block. So okay, at 8 we know that we'll do blood sugars, we'll do vitals, we'll give insulin if needed, and then you'll give your medications. By 10, breakfast is over, trays are cleared, you could give your bath, set your patient up for the day. You've already did your you do your full assessment while you're doing your meds. You will probably prepare them for physical therapy, speech, or occupational to make the rounds. You'll have the rounds by the physicians, toileting, and all of those things. By 11 or 12 is blood sugar time again, if they have it. We'll look at the medications due. We'll look at your toileting. We'll look at the positioning. Are they in pain? Reassessment, all those things. So see, it's like a certain routine, but sometimes coming in blind, you don't really know what the routine is. So 8, 12, and 4, blood sugar times in around standard time for medications to be given. Now sometimes the orders will drop in between, but that's fine. But if you have an overview of what your patient care routine will be, it's kind of easier to stay on schedule. And then if there's interruptions or disruptions, which there will be, you will still have some sense of consistency because you have a routine. And so, again, you may not find this the best, but this works for me. The time blocking. Put your shift into 2 hour increments, right? What is due in that time space? This is not something that's rigid, but I like to think in like a big picture mindset. And so if the details seem to change, I'm more flexible and I don't really get off course because it's kind of already had a system in place. So I hope this helps. Nurse Key here, and welcome back to the new Nurse Bootcamp. All right, so a little bit more on time prioritization and breaking down your 12-hour shifts into time blocks, or even your 8 hours, but I'm just using the 12 hours as a example. Okay, so I made a reference. Okay, now don't talk about my writing, but basically I broke the 12 hours into 2 hour increments. 8, 10, 12, 2, 4, and 6. We know what happens around 7. You get the handoff, prepare for handoff, do your initial assessments. All right, but the remaining of the shift, what do you, or what is expected of you? So by 8, let's say this is day shift, 8, 12, and 5 or 6 is all the meal times. Every 2 hours, you are expected to at least turn your patient, do your eye and nose, the intake and output. What was their urine output? Did they have a stool? And body positioning and pain. Check their pain every 2 hours as well. So at 8 a.m., you're going to get them ready for breakfast, check their blood sugar, administer insulin if needed, if they have coverage ordered, check their vitals, turn or sit them up for breakfast, and then check their eye and nose. At 10 again, you'll go back in. Now, of course, you would get them ready after breakfast and clear them and all this stuff, give your medicines and stuff. But by 10, again, you'll turn, have any eye and nose, if there's any medications to be given. 12, there's lunch coming, vitals, blood sugar, reposition your patient, eye, nose, document. 2 p.m., turn, eye, nose, pain. 4, turn, eye, nose, and pain. By 5 or 6, you'll prepare them for dinner, blood sugars, any insulin coverage, set them up for dinner, and hopefully out of the bed if they're able to. Check their vitals, reposition again, and check their eye and nose. So, or document their eye and nose. So again, this is something that I put on every report sheet, just at the bottom of the sheet, just so once I go through the chart, I see what's ordered. That way I know my plan of care, and this is kind of like the standard that I know. And I just fill in anything else that was ordered per patient. That way I'm able to understand how my day may go, and then I can also report it to the doctors. And then around rounds, when the doctors or the physician teams may round, we're all on the same page, and I can ask any questions about to confirm if they still want to do some things that were ordered or still pending for that patient. So I hope that helps about time blocking. Your shift is only 8-12 hours, but it works better if you have a system, a certain routine to kind of help it flow from day to day. Hey y'all, it's Nurse Key, and welcome back to the new Nurse Bootcamp. So now we're going to talk about medication administration. Now I'm not going to go into like the actual basics of medication administration. You've already learned that for nursing school. Let's put the pieces together and be effective in medication administration. So when you actually become a nurse, you should have like a good grasp on the medication in general. And if you don't, or you're not familiar with a certain medication name or the principles of things or why it's used, then look it up. That's okay. I want to go into how to go from reviewing your medications, pulling them from the Pyxis or the medication storage room, and then actually giving them to a patient. So there are a few principles that you need to know to just have like time effectiveness and actually be safe in your administration for your patient. All right, so first off, you're going to review your MAR. Your MAR is like where the list of medication is. Okay, so first you're going to look at the MAR. This is where the list of medications will be. It'll say each medication, which is scheduled at the time frame that you're anticipating, and sometimes it'll say why. Of course, it'll say the dosage, the route. It will say the It also, most MARs actually have a button where you can actually look up the medication information of like different adverse effects, how to give it, maybe if it has to be reconstituted. There are a few major things to even look at when you're reviewing the MAR. Let's say you have an oral medication, but the patient is NPO and they don't have a peg tube or something, another way of getting them the medicine. You need to clarify this with the physician. Or they're NPO, they have a peg tube, but it does not say that the route of these medications can go through the peg tube. That's something else to clarify with the physician and the pharmacy. So these are things to know. You would know by assessing your patient, reviewing the MAR, and making sure everything lines up really before you get to Pyxis, because it just saves time. And then also, too, you'll need to know if there is medication that is housed in your traditional medication storage place, whether that, if you're in a skilled nursing facility, is that your medication cart, or if you're in the hospital, is that in your Pyxis or your Omnicell room, or is it on stock medication? Some medications are generally have to be sent down by the pharmacy, or it's their home medication, or those are usually the two. So it's good to look beforehand so you can actually request it from the pharmacy, or you may have to order it. If you're in a skilled facility and it's actually not on file, you may have to order it or get a pin for them to pull it. So prepare beforehand. All right, so now you prepared, you reviewed your medication. Some facilities actually have a button where you can actually request it from the Pyxis, so you could check which medications you're going to be given, and you can have the Pyxis or the Omnicell actually prepare it before you get to the actual room. So that's a nice feature. But let's say you don't have that. So now go to the medication storage room or go to your cart, start to prepare the medicine, whether it's your Pyxis, Omnicell, or even at your medication cart in a skilled facility. And you'll prepare, you'll review, compare it with the MAR. Okay, I'm going to pull aspirin. Make sure it's aspirin 81. All right, I pulled the 81. I got one tab. It's one tab and it's 81 milligrams. Okay, cool. Let's go to the next one. I have antibiotics. It's supposed to be as a piggyback. Okay, or piggyback. And then I have the proper supplies with the normal saline and all the tubings. So it's like you are reviewed, and so you kind of have an idea of what additional equipment or supplies you may need while you're pulling the medication. As you're going through the medication, it used to be a long-standing rule that nurses should not be interrupted while they're pulling medication, because it is kind of crucial to prepare medications. You really don't want to have your train of thought interrupted, so try to be in a quiet place and focus on the task at hand. So while you're actually pulling it up, now you reviewed your medications, you prepared it, you're ready to go. Now you can come to the patient. So you're going to do another check. So you're going to come back to the patient, you pull up your MAR, you have your medication in hand, and now you're going to go one by one. Before you even open your medication and really start to, before you actually start to administer it, you're going to now do another check. You're going to go to the MAR. Hey, so-and-so, patient B. Miss B, I have, good morning. I'm going to give you your medication. So we're going to go one by one. I'm going to tell you what the medication is and what it's for. So I have your baby aspirin, 81 milligrams. You may take this at home. You know that generally this is given for blood thinner, just to maintain your heart condition. All right, now I have your blood pressure medicine. I had your hydralazine, and this is for your blood pressure. I've already checked it. Your blood pressure is this, this, and this. Here's that one. And then and then you just go down the list. Be sure that they're able to understand what you're saying. Slow down. Tell them what the medication is and why they're taking it. If they have any questions, try to address it. You don't have to fake it. If you don't know that medication, look it up together and let them know why they're taking it. Sometimes patients say, no, I only want to take this and I don't want to take that. That way you didn't check off your medication before you actually administer it. You check it off actually after you gave it, so you can accurately document what you gave and what was refused. So even with different routes of medication or different forms of medication, let's say oral medication, you want to make sure your patient can swallow. They don't have difficulty or they're not an aspiration risk for swallowing. You want to see if that medication can actually be crushed or split. Sometimes medicines such as potassium most of the time cannot be split or broken. You have to make sure that format of the tablet is one that can be broken. and know how your patients take their medicine. Are they able to take it whole? Do they have to have it crushed, or do they need even whole in applesauce? So ask them their preference, or even their pill split, and then have the appropriate supplies at hand. So it just saves time. All right, with PEG tube, NG, and G tubes, if that patient has one of these tubes, you would have to prepare and say, okay, I know I need sterile water. I know I need a syringe. I know I need a, but it's like a little container, the cylinder container for, excess water to draw up their medicine. I know I need a pill crusher to crush the pills and then add to the water. So certain supplies beforehand. These are all things while you are reviewing. You can make a running list of what supplies you need additional to the medicine, just to save time and cluster your care while you're in the room. What else? Now, IV medications. Of course, if you're hanging IV medications, or if you're replenishing a IV infusion bag, you'll think of, okay, do I need another bag? Do I have the proper tubing? Did I have the labels to label my tubing? Do I have alcohol swabs? Do I have the saline flushes? Do I have the green Curos caps? If I have to reconstitute it, like I'm giving like even Protonics, do I have the proper solution to reconstitute that to make the proper dosage? Do I have the adequate needles, whether it is, or if I'm giving even an injection, do I have an IM needle versus a sub-Q? Do I have a blunt needle to draw up my medicine? So these are all things that while you're at the computer, while you're at the MAR, and before you get to the patient, before you start pulling medicine, review, take a moment, take a deep breath, think of what's before you. Think of how you're going to give the medicine to the patient effectively and accurately, and which routes, and what does that dictate, and what supplies that you need. So I hope this helps. Again, this is New Nurse Bootcamp. We went over medication administrations as a nurse at the bedside. I'll see you for the next episode.